We just got off the floor, folks. Staff, thank you so much for being here and putting up with us. Conferees, thank you very much for being here and sitting in those very hard chairs back there for that. So I'm going to get right to it. I'm going to open the hearing on House Bill 2223. And with that, Carly will give us an overview. Carly, thank you.
Thank you, Mr. Chair. Good afternoon, committee. House Bill 2223 modifies certain provisions of the optometry law relating to scope of practice, definitions, and credentialing requirements. Section 1 amends KSA 65-1501 to specify the procedures that would not be included in the practice of optometry. Section 1 also includes in the practice of optometry the performance of additional procedures that are not prohibited in subsection B and are within the scope of a licensee's training and education pursuant to rules and regulations adopted by the Board of Optometry. Section 2 amends KSA 65-1501A to remove the definitions for the terms topical pharmaceutical drugs and oral drugs. Section 3 amends KSA 1505 to add a subsection G, which states that any licensee who is applying for credentialing by the board shall complete an application form, which would be furnished by the board, and pay a fee, which would be determined by the board through rules and regulations and would be in an amount necessary to reimburse the board for the cost of credentialing. Section 4 amends KSA 65-1509A to require the board to establish credentialing requirements for a licensee to administer or perform the procedures set out in KSA 65-1501A4. Section 5 amends KSA 65-1512 to name the provisions of Article 5 of Chapter 65 of the Kansas Statutes Annotated and amendments thereto, the optometry law. Section 6 amends KSA 65-1523 to allow the board to apply to a court for injunctive relief against any person to restrain violations of this act. Section 7 amends KSA 74-1504 to provide that the board may maintain and make available to the public a directory that includes the names and addresses of all optometrists licensed by the board. House Bill 2223 would take effect on July 1st, 2025, after publication in the statute book.
Very good. Thank you, Carly. Committee questions? Seeing none? Thank you very much. Okay, getting right along. First proponent, Todd. Todd, welcome to committee.
Good afternoon, Chairman Carpenter, members of the House Health Human Services Committee. My name is Todd Flesher. I'm the Executive Director for the Kansas Optometric Association, which represents optometrists across the state. I appreciate the opportunity to be in front of you today in support of House Bill 2223, which modernizes the Optometric Practice Act to reflect contemporary optometric education and training. The revisor did a great job explaining kind of the tenets of the bill, and I'll let the doctors that go behind me kind of explain the procedures that are outlined, but I wanted to give you a little bit of background about how we got here today. And I know that you all love scope bills, so I appreciate you having the hearing and getting us to have this conversation with you. So the Kansas Optometric Association actually celebrates 125 years this year. And so as you can imagine, for the last 125 years, the profession of optometry has evolved pretty dramatically. There have been advances in education and treatment options, training, and just technology. And so periodically we have to come before your organization and ask for changes to the Practice Act to reflect those changes. The most recent change significant change for the Practice Act was actually back in the late 90s. So as you can imagine, over the last 25 years, there have been additional changes in technology, training, treatment options, and different things like that that affect the ability for optometrists to be able to take care of their patients. More and more, we're seeing optometrists that are frustrated. They have a really good relationship with their ophthalmologists and other healthcare providers in the community. They work hand in hand to make sure that the patients get the best care possible. But one of the things that they're frustrated about is the ability that if they are trained and educated to provide these procedures, they're having to have patients wait on care with some of their ophthalmology colleagues because of just getting in to see those doctors. And sometimes they're sending patients either out of town or out of state to get that care because there's not an ophthalmologist in their community. That is a burden on patients and often caregivers, as those patients are often older and are unable to get there on their own. So that's just a frustration that optometrists are having, and as we have more and more optometrists coming into the profession from that have graduated from optometry school and coming back to the state to practice, that's a concern that they have. They want to be able to practice to the level of their education and training. We're also seeing that happen with our students. As students go away to optometry school, they are learning the procedures that are outlined in the bill. They want to be able to practice those when they graduate, and now they have multiple options about where they can go after school and practice those to the full extent of their education and training. That's a concern. The reason for that is the numbers of ophthalmologists are declining nationally, and even in rural areas it's even more significant. But the numbers of optometrists are going to be declining as well because those students aren't wanting to come back to our state to practice because they can't practice to the extent of their education and training. So that's kind of where we're at right now. We actually had, we started this conversation back in 2019. We met with ophthalmology on numerous occasions to talk about the concerns that we have and the desire to practice to the level of current education and training. During those meetings, we were not successful in moving the needle and having those negotiations to allow doctors to practice to the level of their extent of their training. We actually introduced a bill in 2020, which, if you remember 2020, that probably wasn't the best year to introduce a bill. So during midway through session, we just let it go and let our doctors focus on taking care of their patients, their families, and their communities. We brought the bill back up in 23 and met with ophthalmology and medicine again to kind of share the concerns that we had and the reason that we needed to address this issue. We brought a bill forth last year in 24 and had a hearing in Senate Public Health, but the bill was not worked. We met again this December. And went over the concerns, again, that we have and the need for this bill, and let them know that it was going to be very similar to the bill that passed previously. So that's kind of where we're at today. We introduced the bill earlier this session. We have the hearing today. The bill is, as the revisor laid out, is very specific about here's what optometry is, here's what it isn't. We put specific guardrails in the bill to make sure that there were safeguards in place so that it was very clear that optometry wasn't asking to practice beyond their education and training. For example, there is a prohibition on optometrists offering cataract surgery or retinal surgery or intraocular injections, those kind of things that were very specifically outlined in the bill, that those are exclusions to the Practice Act, that optometrists are not able to do that. So we tried to be very proactive and address those concerns head on. Despite all of this, you know, the conversations that we've had, the concerns that you're going to probably hear today, the same concerns that we heard in those conversations they're about safety. I think there are 12 states that have passed these provisions, and there has been a strong track record of safe delivery of care in those states. The malpractice rates in those states are reflective of that. And I know that that doesn't exactly equate to patient care, but it does show that if an insurance actuary felt like these were high-risk procedures for optometrists to be doing, they would reflect that in the rates. Kansas optometrists pay the exact same insurance rates or malpractice rates that they do in Oklahoma, where they've been doing these procedures for more than 25 years. So we are here today to ask for your support. With my testimony, there are a number of letters from patients that are expressing their desire to have a choice. They respect their ophthalmologist and their other healthcare providers, but they want to have a choice if they want to stay in their community and get the care from their provider who is educated, trained, and certified to provide these procedures. With that, I will stand for questions at the appropriate time, and we hope for your support for House Bill 2223.
Committee questions. Representative Ruiz.
Thank you, Todd, for your testimony. And I have a couple of questions if the chair will indulge. The first one is, how many schools of optometry are in Kansas?
There are 0.
Okay. And would this bill increase access to health services, eye health, into our rural and frontier areas of the state?
We believe it will.
Okay. Thank you, Mr. Chair.
Committee, further questions? Representative Blex.
Thank you, Mr. Chair, and thank you, Todd, for being here. When we say changes in technology and reading over what they can do and the changes, a lot of that, at least a couple applications, appear to be setting up a machine to help work the situation of laser and eyes. And is that what you're saying in changes in technology?
So if you think back to what technology was 125 years ago to now, there's pretty significant changes in the technology they use to examine your eyes. I know that I'm going to leave it up to the doctors to explain exactly those specific changes so that they can talk about how when they started practicing versus how they do it now. But there are significant changes in the delivery of eye care across the country.
I guess more and more, Mr. Chair, I guess probably what I was getting at, can a lot of these procedures now be done with the aid of a machine as opposed to, you know, the hands that may have done it years past?
So I think that machines in conjunction with the professional judgment of their education and training.
Okay, thank you for that.
Representative Turner.
Thank you, Mr. Chair. Say, on the topic of patient safety, you pointed to the malpractice rates being about the same. Are there other broad measures like incidence of complications or anything else that would kind of at a high level give us a feel?
Certainly, there are studies out there that show that there are about 146,000 procedures that have been done by optometrists. And of those, we're aware of 2 complications that are of a concern. Obviously, there are, nobody wants a bad outcome, but 2 out of 146,000 is consistent with other healthcare providers.
Committee, further questions? Seeing none, thank you, Todd. Next, we have Dr. Shane. Thank you. Welcome to committee.
Thank you for allowing me to be here to show my support for House Bill 2223, the modernization of the scope of practice of optometry. My name is Dr. Shane Canar. I'm an optometrist in Southeast Kansas, where I grew up. I attended Pittsburgh State University, where I met my wife, and finished my training and education in St. Louis. The entire time, my wife and I knew we wanted to raise our family in Kansas, and in 2009, we opened Canar Eye Care in Pittsburgh. That's since grown to a multi-doctor, multi-location practice, in part because of the need for eye care in our rural communities. A little bit about my practice. In a day, we do see refractive patients, myopes, hyperopes, but a large percentage of my day is providing medical eye care, diagnosing, treating, and managing conditions, referring for surgical management when it's indicated, postoperative and preoperative care for those patients, as well as being an integral member of our healthcare community in Pittsburgh. We provide call coverage for both hospitals in Crawford County, which serve a broader area than that, being the only providers that live in our community. We also work closely with community health, Medicaid, and other social groups in order to provide care for patients of all socioeconomic positions. And I think that's very important because at times as these discussions have happened between optometry and ophthalmology, it's somewhat been considered that optometry is moving from a refractive profession to a medical profession with this scope change, and that could not be further from correct. I've been managing patients medically since my graduation in 2000, and this bill does not change that. 2 key topics come up as we have those discussions as well: education and complications. And I would like to address both of those. And when I talk about it, unlike the opposition, I would like to talk about facts versus assumptions. Our education is not medical school, but our education is robust and rigorous. After 4 years of undergraduate, I had 4 years of optometry school, 10,000 hours of education in pharmacology, systemic disease, ocular disease, management of disease, and clinical procedures. I also learned a physical skill set that allowed me to perform a variety of procedures that equate to my foundation to learn these procedures. While our education is not the same, it is vigorous. In fact, to highlight the procedures outlined in House Bill 2223, it's the excision and removal of cyst, chalazion, skin tags from the eye and adnexa, as well as 3 specific laser procedures: YAG capsulotomy, SLT, and peripheral iridotomy. Those procedures, all graduates since 2017 of optometry schools in the U.S. have been trained on. And for more than 25 years, optometry students have been trained at certain schools. For maybe older, more seasoned practitioners like myself, I did learn and refine the skills necessary to perform these procedures through continuing medical education that happened at universities, schools, clinics, and meetings. just the same as any other health professional learns new techniques and procedures as their career continues to evolve. Our bill also specifically excludes, as Todd mentioned, certain procedures that we do not feel our profession is adequately trained to perform. And I think we have to address manpower, as was brought up earlier. There is a shortage of eye care in Kansas, especially rural Kansas. In fact, as president of our local hospital board, I can say that there's a shortage of health care in Kansas across all facets. But ophthalmology, in one recent study, is expected to soon be the second most underserved medical specialty in the United States. Rural Kansas is directly reflective of that. In my practice, we've found several workarounds for these manpower issues. We do bring an ophthalmologist to our clinic 1 day a month to provide the procedures that they are able to for our patients. A significant proportion of their time is spent performing and evaluating for procedures that I'm trained, educated, and certified to do, instead of the procedures that only they have the skill set to provide my patients. The other option is referral out of my community. That may be out of state to Joplin, but that could also be a 2-hour trip to Kansas City or a 3-hour trip to Wichita. That's a burden not only on the family, but the patient. And there's irony that exists because 45 minutes away, I could take these patients to a neighboring state and perform these procedures for them today. Along with this, the third facet of our manpower situation has been providing co-management or post-operative care for these patients. Since I began my career, I've been providing for patients for the procedures outlined in House Bill 2223, as well as more complex non-office-based procedures from the day after surgery on. Treating and managing complications is not a new scenario. And that does bring us to complications. And I think it's important that we think of complications in the right light. You know, a favored time of any profession is to sit around and tell the story about a complication or a diagnosis and how it could have been handled differently. I will say this, any medical procedure has complications. If optometry is to be held to a standard where no complications would arise, then all professions should be held to that standard, and that's not possible. The real answer is, does the rate of complication change? Are there more complications? There's 2 recent studies that I would like to point out. One is a review of 20 articles, peer-reviewed articles around YAG capsulotomy, and the optometrist performing those procedures had 0 complications. The other that Todd alluded to is a study of 146,000 laser procedures performed by optometrists. There were 2 complications, not 2%, 2. That rate of complication is equivalent or better than these same procedures provided by medical doctors. All this leads me to say that I know change is hard and change is difficult. As a profession, we've done our due diligence to make sure that the education, training, and certification are in place before we approach Kansas about modernizing our scope of practice. While I stated that the education is different between our professions, what is not different is our professionalism and commitment to patient care. I could not be more proud of the colleagues I practice with, and I cannot say how thrilled I am to stand before you and say we waited till 2020 to pursue this modernization of scope because we wanted to be sure that when we started providing these procedures for the patients in Kansas, they would have the outcomes and the quality patient care that our citizens deserve. Thank you for your support of House Bill 2223.
Thank you very much for that. Committee questions? Representative Bueller.
Thank you, Mr. Chair, and thank you, Dr. Canar, for being here. So I just want to make sure I understood what you said. And you're not one of those who's graduated since 2017. I think you referenced
good assumption, by the way. Yeah.
Our similar hair color kind of tipped it off. So I'm curious though about the 3 procedures that are referenced in this bill. The YAG capsulotomy,
The 3 laser procedures to be just okay.
Yeah. So you weren't trained in those when you were in school 24 years ago, 25 years
Not to
ago?
the level we are now at that point in time, but the skill set that was required, using a slit lamp, performing gonioscopy, the clinical portion or requirements we were trained on, but at that point in time, the school I attended in St. Louis was not training us to complete those procedures.
Okay, so time and technology pass and increase. So can you do those, or have you learned to do those, or how will you learn to do those? I guess I'm just trying to do an assessment of your current skill
I
relative
have.
to
I
this.
attended continuing education, and again, it's a refinement of techniques we have, but we attended a tested continuing education, an extensive course in how to perform these procedures.
Okay, so if I may, one follow-up question. So you can do these procedures in Missouri, but you can't do them in Kansas, is that right?
That is incorrect. Arkansas and Oklahoma.
Okay.
Missouri is actually having these same discussions.
Okay, so in at least 2 of the neighboring states, you can perform these procedures?
Yeah.
Okay.
Yeah, 12 states in the country at this point in time. And I think that's interesting because if we take 50 states, you have 12 early adapters, 12 maybe late adapters, and we're in that middle 50% because we did do our due diligence and want to make sure that we had those positive outcomes. And there's greater need in rural communities for these type procedures to be provided by other providers.
Okay. Thank you, Doctor. Thank you, Mr. Chairman.
Representative Blex.
Thank you, Mr. Chair, and thank you, Doctor, for being here. Assuming I drive to your Pittsburgh office from Independence and you give a diagnosis, you think I may have a condition that needs an ophthalmologist, basically second opinion, you schedule another appointment, I drive that distance again. When the ophthalmologist comes, does he or she have the equipment necessary to do the procedures that may require in your office, or will I have to turn around and get a referral and drive to Wichita for the procedures done?
If it's okay, I'm going to say neither. That equipment's not available in my office,
Okay.
but you would be scheduled back to come to our local hospital at his next visit. He does perform procedures twice a month in Pittsburgh, but only has clinic one day. So for the evaluation before, and then you'd have to come back 2 weeks or a month or 6 weeks or 8 weeks later for your procedure.
Thank you for that.
Any further questions? Representative Weichel.
Thank you, Mr. Chairman. To that last point, so the expanded scope of practice that you guys are asking for in this bill, will that all be able to be done in your office, or will some of that will be done in hospital settings?
So there could be the laser required for the procedures. It's something that my practice may purchase at some point in time, but at this point we would utilize our local hospital to do it. I do think the need's there to support a laser in our office, but those are all questions to be discussed.
Representative Berquist.
That answered my question. Thank you, sir.
Any further questions? Representative Ellis.
Thank you, Mr. Chairman. On the lasers, the laser procedure a long time ago, like 20 years ago, has been educated for a long time, I understand, from the people that are in my county. But there's a new laser program, and maybe you've answered this, just in the last 5 years. If they're not trained in it, do they want to be able to practice that?
I'm going to have to get, I'm not sure what
New laser light, I know that's redundant.
So light adjustable IOLs
Yes.
possibly?
That's it.
Hey, we're on the same page here. Light adjustable IOLs. That is a different procedure. I think it's something that should, if not be clarified in our law, but that is different than these procedures that exist.
Is it going to be allowed?
It should be allowed. Yes. Yes.
But what about the, let's say, more mature doctors? How will they be trained in it?
Well, it's the same whether that be a family practice doctor, whether that be a dentist, anything. As new procedures, we have to go through continuing education if we want to perform those procedures. And that's where I'm so proud of our certification process that we've touted. Just because I'm an OD doesn't mean that I can do them. I have to prove that I've been competently trained and competently perform those procedures. And that's the safeguard that we want in place to make sure that that happens. So the same would be addressed for light adjustable IOLs. We would have to know that provider, and our state board has an extensive history of making sure that our providers put the safety of our citizens first.
Thank you. Thank you, Mr. Chairman.
Representative Turner.
Thank you, Mr. Chair. Say, following up to Representative Blex's question and your response, I just want to make sure I'm hearing it correctly. So I think the question was about in today's times when you have an ophthalmologist in your office 1 day a week, he was saying he'd have to come in, get diagnosed, then come back, go to the hospital. Or was that in a world where this bill has passed and you're able to do all that in one package?
That's in today's world. There's no way that a laser can be justified for 1 day a month for these procedures in my office. We have to refer so many patients out of state to Kansas City. We dilute the patients that this provider can see coming to our office because he can't handle the need that's in our area.
So to sorry.
So, yes, that exists currently.
So to contrast then, his same experience where he drives to your office, you would have been able to handle him in his initial appointment rather than come back later? Is that correct?
It would depend on the scenario. I mean, and I hate to answer that, but I think
see.
that would be across all professions.
That's fair enough. Thank you.
Committee, further discussion. Representative McDonald.
Thank you, Mr. Chair, and thank you so much for being here today. I was wondering if you could give us a couple examples of specific disease or problem that's being treated with these lasers and cost versus maybe treating them in other ways.
So the specific 3 procedures that we have outlined are pretty unique to their condition. So capsular haze is a product that arises following cataract surgery in the majority of patients. So the lens capsule remains intact after the cataract surgery, and over time that may become cloudy. So a YAG capsulotomy opens that. It could be done surgically, as somebody mentioned earlier, with hands, but that would be high risk and low reward and not the way that that's done. As far as the treatment with SLT, which I think is probably the most second you said too relevant point here, it's one of the treatments for glaucoma, a disease where one of the things we would attempt to do is lower pressure. There are drops that are available, topical therapy. I think everybody would agree that those are an ongoing and expensive burden for patients. We're seeing SLT grow as a primary treatment for glaucoma. And I think it would be advantageous for many of my patients, not only for compliance, but for cost and cost burden to the healthcare system. Unfortunately, while we offer it as much as we can, the burden to access makes it very difficult for a lot of my patients. So I think when we look at that, it's another reason that we definitely see the benefit of being able to perform these procedures.
Okay, if I have one follow-up.
You may.
If they do these drops, is that something they have to be on forever?
Yes, most
okay, so
likely.
I just have some concerns about perhaps low income or rural people who have a hard time with compliance or affording
It's not just low income or rural people. Compliance is an issue with glaucoma therapy. If you're 50 and I tell you that you're going to be taking drops for the rest of your life, and there's also concerns with preservative and corneal toxicity, and there's all these other things that go into play. And as part of the reason we're looking to modernize our scope is we are primary eye care providers, and as this procedure moves into that realm more, we need to be able to offer it for our patients.
So how long would glaucoma fix this problem? Would the surgery, the laser surgery, fix the glaucoma?
So you know, there's a variety of ways to do the procedure. I'm going to give a vague answer, which is, let's say a 3 to 5 year cycle. We're now looking at a shorter energy delivered, and that being repeated annually. Some patients get longer benefit, but that kind of gives you an idea or a realm. But once it's done, it's done. There's no patient compliance involved.
Okay, thank you very much.
Very good. Thank you very much, Doctor, for that. Next, we'll move on to Nate. Welcome to committee.
Thank you, Chairman Carpenter and members of the committee. My name is Dr. Nate Lighthizer, and I am testifying in support of House Bill 2223. I'm an optometrist and faculty member, and I currently serve as the dean of the NSU Oklahoma College of Optometry in Tahlequah, Oklahoma. I'm a North Dakota boy, born and raised in Bismarck, North Dakota. Did my schooling in Oregon, and then came down to Tahlequah, Oklahoma to finish my training, and have been fortunate to be there for 16 years. So I served as a junior faculty member, and then what rose up through assistant dean, associate dean, and currently the dean. I'm here to talk about the education and training of optometrists, as I am the dean. and are very familiar with education and training in optometry school. Actually, tomorrow at this time, I will be in Portland, Oregon, along with the deans of the other 23 colleges of optometry, as we have one of our quarterly meetings tomorrow. Optometrists are incredibly well trained through optometry school in laser procedures, specifically the three that you're talking about: YAG capsulotomy, laser peripheral iridotomy, and SLT, along with the eyelid procedures and injections that are outlined in this bill 2223. Our students start in the first year of their optometry school. First semester of their first years, they learn optics, and they learn anatomy, and they learn a variety of different things in their first year, and that continues through second year, third year, and fourth year. I was in clinic yesterday and Monday morning with fourth-year optometry students, where we did more than a half dozen laser procedures, specifically the ones that are outlined in this bill: YAG capsulotomy, SLT, and PI. So I can assure you that education and training happens extensively from year 1 through year 4 in optometry school. How does that training happen? It obviously starts in the classroom. It's going to start as they attend classes, lectures, intensive, rigorous courses as they learn the foundational principles of these procedures, among a variety of others. And then they go to the laboratory. Hands-on laboratory training, where we have the actual lasers, the YAG lasers, the SLT lasers, where they learn on model eyes and train in the laboratory setting on model eyes. They are tested on both. They have written examinations and they have practical examinations. And then, as you heard just from a couple of days ago, they are then doing procedures in our clinic under the supervision of an attending doctor. It was myself Monday and Tuesday morning. So optometry students, for the last 5 to 10 plus years, and for the last 30 years in Oklahoma, have been receiving extensive education on these procedures. As Dr. Canar outlined, so what year did you graduate?
2000.
You're welcome. Yeah. So it happens now in 2025, and it has for the last, again, 20 years in Oklahoma and last 5 to 10 years in other states. Well, what if a doc graduated in 2000? I'm sure all of you agree, education and training does not stop the day that you graduate. I graduated in 2009, and I am not limited to 2009 technology. I'm not limited to 2009 procedures. Education and training advances. I happen to lead the training and education course that travels around the country and has trained the doctors in Kentucky, in Louisiana, in Colorado, in Arkansas, and other states that do these procedures. We've been to every one. I've been fortunate to lecture in 49 of the 50 states and do this laser and surgical training course in 37 of the 50. Education and training does not stop the day after school. It's an intensive 4-day course where they get, again, laboratory hands-on training, educational training. I had it recently, 4 years ago, an ophthalmologist attended the course, and he commented, "I wish we had education and training like this when I had to do my first YAG capsulotomy, had to do my first SLT. I was thrown into a room and said, here you go, figure it out." The education and training is robust. And even if a doctor graduated in 1990, 2000, 2010, there is a mechanism in place that has proven successful in the 12 states that currently authorize optometrists to do laser procedures. I was the lead author on the 2 studies that Dr. Canar mentioned, a YAG capsulotomy study. We had 9 locations across Kentucky, Louisiana, and Oklahoma, where we did a lot of YAG capsulotomies and showed that 99.5% of patients were satisfied with their outcome, and there were 0 complications in that study. I was also the lead author on the review, and we contacted the state boards in Oklahoma, Kentucky, Louisiana, all the states that authorized it, and they track these procedures. And there was over 146,000 tracked procedures with 2 complaints registered to state boards. 2 out of 146,000. Again, data is out there, published literature. Certainly, Dr. Canar mentioned complications. Complications can happen. I've done over 5,000 laser procedures myself in Oklahoma. If I moved to Kansas, I would not be allowed to do them. It's one of the reasons I told you I'm a North Dakota boy. Where do I practice? In Oklahoma, because I can do what I was trained to do in Oklahoma. Have I had complications in 5,000 procedures? The answer is yes. Have I had eye pressure spikes where the eye pressure goes up a little bit? Yes, and you handle those with drops afterwards. Can you develop some inflammation in the eye after a procedure? The answer is yes, and we handle that with drops. I remember one of the first complications I had, I called one of my mentors. He's actually an optometrist and an ophthalmologist. And I said, "Doc, you know, I had a complication, we're managing it." And you could tell I was a little down. He goes, "Nate, the only way that you will never have a complication is what? If you don't do the procedures." Any provider, whether they're an MD, DO, optometrist, dentist, nurse, if you do procedures, you are going to have complications. Fortunately, they are very, very rare, as outlined in those studies, and I can testify in clinical practice as well. So, as the Dean of our College of Optometry, I'm very familiar with the students coming in and the students graduating. I can tell you that 19% of our students that apply to the Oklahoma College of Optometry are Oklahomans. 19%. 81% of our students that graduate stay in Oklahoma. 19% are Oklahomans coming in and 81% stay because they want to be able to practice to the level of their education and training. With that, thank you, Mr. Chairman.
Very good. Thank you very much. Representative Steens.
Thank you, Mr. Chair, and thank you so much, Doctor, for your testimony. So I'm just going to ask an obvious question, and maybe it's kind of a dumb question, but you have all this training, right? We've heard from the other doctors as well, and it's being done in all these schools. Is that correct? In most of these universities, we're getting this same training with the lasers and these different procedures?
Correct. 24 schools, yes.
So, and it's only passed in 12 states. Is there like a national board that made some of these decisions and then you've had to go by states? Because I'm hearing this and I'm thinking, if you're trained in all these procedures, why are the states not allowing you to do the procedures?
Optometry is a legislated profession, and each state has their own set of rules and regulations. It's different in North Dakota than it is in Oklahoma, that is in Kansas. We do have national board exams. They're called NBEO, where our students take those, Part 1, Part 2, and Part 3, but that does not regulate the scope of practice in each state. Each state's legislature determines what the rules and regulations are for optometry.
Can I have a follow-up? Sorry. So you're saying, but in all these states, it's completely different. Like these, is it these particular procedures that we're discussing here are pretty uniform across all these states, or it just varies? Like maybe one state allows a couple of these procedures?
Correct. Correct.
Okay.
12 states authorize laser procedures. Most of them are very similar to this bill. Those are the 3 laser procedures, or 3 main ones that optometrists are doing: YAG capsulotomy, LPI, and SLT. But again, every state's different. Massachusetts just got the ability to prescribe glaucoma drops in Massachusetts. There was 49 of the 50 states in the union. We've been prescribing glaucoma drops since what year in Kansas? 96. Since 96. They just got that in Massachusetts 2 years ago. So every state is a little different.
Thank you.
Representative Rivas.
Yeah, if I may, Chairman, I've got 2 or 3 questions to kind of relate.
You may.
So thank you for your testimony. I appreciate that.
Yep.
So my question is regarding your studies. Were those double-blind, blind? Were they peer-reviewed? How were those done?
Yeah, those were peer-reviewed studies that went through the publication process, peer review process. They were not blinded studies, as we didn't have a masked examiner on that. We performed procedures in clinic, the laser procedures in clinic, just like we do, and we registered all the data, collected all the data, and published that. It was peer-reviewed data.
Was any of that sponsored by a laser company as far as cost or anything like that? Is it strictly academic?
None of that was sponsored by a laser company.
Thank you.
Very good. Representative Weichel.
Thank you, Mr. Chairman, and thank you for your testimony. A question about the training comes to mind because I just spent quite a bit of time this weekend in our optometrist office for my children. The training, like, do the doctors get pediatric training in this as well, or is it all on adults, or kind of what does that look like?
Specifically in regards to these procedures
Yes.
outlined in this bill?
Yes.
The answer is yes. It is very, very rare that a pediatric patient, defining under the age of 18, it's very rare that somebody under the age of 18 would have glaucoma. It's not unheard of, but it's unusual. The youngest patient that I've ever done a laser procedure on would be in their 20s. So I've never done an SLT or a YAG capsulotomy. YAG capsulotomies are after cataract surgery, and most 15-year-olds don't need cataract surgery. So it'd be very, very, very unusual if somebody under the age of 18 would need one of these laser procedures.
Committee, further questions? Seeing none, thank you very much for, Representative Bryce, sorry.
Thank you, Mr. Chair. Thank you, Dr. Lighthizer. I'm sorry, Lighthizer.
That's fine.
Did I say it right? Okay.
Dr. Nate is what I'm known at the school. That's much easier.
Okay, I'm Rep. Ron then.
Yeah.
Okay. Yeah, we had spoken before, and you described in detail some of the things you do in Oklahoma. I had a question about when you have students who are learning these procedures, how difficult is it, would you say, for the average student or for the procedures listed in this bill? What would you say the degree of difficulty is to teach these students the skill? Thank you.
It depends on the procedure. We actually have, these 3 procedures. The degree of difficulty, a scale of 1 to 10, I would, on the low end. It's too, I watch a lot of first lasers being in an optometry school. Again, I did a bunch of them on Monday and Tuesday where I'm standing watching on the TV screen as they're doing the procedures. And I will tell you, in 1 to 3 procedures, they have picked it up very, very nicely. They've done a very good job. So the level of the learning curve of this is picked up very nicely because they've spent a bunch of time on the slit lamps and they've done a bunch of gonioscopy. But the learning curve is very, very doable. And again, I see a lot of first procedures going, that went really, really well. And so 1 to 3 procedures and they've picked it up very nicely. So the learning curve is quick.
Thank you, sir.
Yep.
Representative Howell.
Thank you, Chair. So as I'm listening to your testimony, and you said you've done a lot of instructing and teaching, and is my understanding that you traveled around teaching in numerous places, is that correct?
Correct.
And so I assume probably not all these locations were necessarily located at colleges, is that correct?
That is correct.
All right. So I know that some criticism has been that sometimes these are like perhaps maybe at hotels or places like that, or conventions, things of that nature. Would that also be correct?
The vast majority of conferences are going to be put on at a continuing education vet, which is usually a hotel in a ballroom. Occasionally put these on at schools as well, but that's where most continuing education happens.
It's okay, Vassar. And would you say that most industries, including medical industries, travel around to conventions and get continuing education at locations like that?
That is correct. Yes, I've been at many conferences where there was dentistry and medicine, and I've had education training alongside my ophthalmology colleagues. Yes.
Representative Bryce.
Thank you. Thank you, Chairman. Thank you, Dr. Nate. Just one quick follow-up. It's kind of a hypothetical, but you'd mentioned that it's fairly easy to train optometry students these procedures. Maybe by the time they do 3, they pretty well have it. And this is a hypothetical, but I'm just curious of your answer. Why does someone have to be an optometrist to learn these procedures? Why couldn't you train a smart person off the street? Thank you.
Because you have to have that foundational knowledge of going through an optometry school, an ophthalmology residency. I mean, when you go through optometry school and you go through ophthalmology residency, that is the building blocks for understanding dry eye, glaucoma, laser procedures, slit lamp, gonioscopy. Our students have hung out in the angle of the eye, which is the drain of the eye, a long time with gonioscopy before they do SLTs. So they have that foundational knowledge of optometry school, and they've built upon that. And you add a new skill. That's my brother-in-law is a dentist, and he went through 4 years of dental school to build upon his foundation, and he adds new procedures and skills every so often. And you couldn't do that with my sister because she doesn't have the foundational knowledge of going through 4 years of school.
Thank you, Mr. Chair. I'd have to say I totally agree with you on that, but I don't know. It seems like you're making the argument for the other side as far as needing to have a foundation of being a medical doctor, a physician, being able to treat complications, being able to treat acute emergencies during these procedures. An optometrist, of course, is not a medical doctor. And it seems like I would use your argument, but just what would you say to that? Thank you.
I would say that the 4 years of optometry school provide the foundational knowledge of going through all of the disease states that we talk about, how to cover an IOP spike, whether it's from a laser procedure or just it happens, whether inflammation happens from a laser or something else, that the foundational knowledge is there through 4 years of education and training, not on just glasses and contact lenses, but all of the ocular diseases that we intensely cover. So the foundational knowledge is there. It's different, as Dr. Canar said, not medical school, but it's optometry school.
Very good. Thank you very much.
Very good. Thank you very much for being here. committee, we're going to need to move on if we're going to meet our goals. So with that, Derek?
Thank you, Chair. Good afternoon, Mr. Chair.
Can you hear us fine?
Yes, I can hear you. Can you hear me?
We can. Very good. Thank you.
Awesome. Thank you for letting me be here today. My name is Derek Bryant. I'm a native Kansan from Winfield, Kansas, and I'm currently in my final semester at the Oklahoma College of Optometry. I also serve as the president of the American Optometric Student Association, representing over 7,000 optometry students nationwide. And I'm here today to respectfully request your support of House Bill 2223 and to explain why this legislation is so important to Kansas optometry students. So first, no matter which optometry school we attend, Kansas optometry students are trained to perform these procedures outlined in this bill and want to practice at that level upon graduation. We actually surveyed Kansas optometry students and found that 90% consider scope of practice an important factor when deciding where to practice, and 96% said they'd be more likely to return to Kansas if scope modernization were passed. As someone from Winfield, Kansas, only 25 minutes from Oklahoma, it's difficult to know that merely crossing a state line means I can practice to my fullest ability and offer my patients a higher level of care, something I can't currently do in Kansas. Just like you, I want to see our state thrive and remain an attractive place for new optometrists, but that won't happen without this bill. Second, with this bill, we aren't asking to do anything new or untested. We're simply seeking deregulation so that we can perform procedures we are well trained and already licensed to do in neighboring states, such as Colorado, Arkansas, or the state I'm in currently, Oklahoma. In optometry school, as Dr. Nate said, each skill we learn starting in our first year builds on the next. I've spent 4 years training to perform these procedures, and I myself have already performed these procedures on live patients as part of my training. And returning to the state that I was born in doesn't negate the skills that I've acquired or that I've demonstrated proficiency in. And our laws in Kansas should reflect the level that we're trained to practice. And this bill will help do just that. My final point here is that as a native Kansan and future optometrist, it's important to me that we keep Kansans' eyes healthy. And this bill prevents residents from delaying care that a highly trained optometrist in their hometown could readily provide. We've talked a lot today about how they're having to drive hours away and maybe multiple appointments, and having that access in their hometown at the optometrist they already see would be a great thing. The only barrier in Kansas is our current scope of practice, which disallows these procedures that we spend 4 years training to perform. Optometry students and optometrists train extensively. We prove our proficiency in school and on board examinations, both at national and state levels. And we're keeping up to date through extensive continuing education and are already performing these procedures in neighboring states, just like I did earlier this semester. And as an optometry student from Kansas, representing students across the nation, but my fellow Kansas students, I sincerely ask for your support of House Bill 2223 and encourage you to pass it favorably. Thank you for your time today, Mr. Chairman, and your attention, and God bless.
Very good. Thank you. Committee, a few brief questions? Seeing none, thank you again for being here, Derek. Next, we have William Wilkes. William, welcome to committee.
Thank you, Mr. Chairman. Good afternoon, Mr. Chairman, members of the committee. My name is William Wilkes, Senior Director of Government Affairs for the Kansas Chamber of Commerce. The Kansas Chamber appreciates the opportunity to provide proponent testimony on House Bill 2223, a bill modifying the scope of practice for optometrists. As you've heard, this bill would allow optometrists to perform procedures they are trained to do in optometry school. Medical technological advancements have enhanced and continue to improve patient care and, most importantly, patient outcomes. Unfortunately, our state statutes for optometrists have not kept up to date with the advances of education and medical technology. The Kansas Chamber is expressing support for this bill from a workforce perspective for optometrists. We also believe this bill would increase the access to optometry treatment for Kansans, along with reducing wait times. As you've heard, 12 other states have passed this scope of practice bill to allow optometrists to perform these procedures. The Kansas Chamber will continue to advocate for reform of our healthcare statutes to keep pace with the advancements of medical technology while not sacrificing the safety of Kansans seeking and receiving treatment. With that, thank you for the opportunity to testify, Mr. Chairman, on House Bill 2223, and I'm happy to stand for questions.
Very good. Thank you for that, William. Seeing no questions, thank you very much.
Thank you.
Okay, next, committee, I'll bring your attention to the written proponent testimony here on the agenda. And with that, and we'll get him out of time up here quickly, so maybe he can get back on the Senate floor. Senator Clifford, welcome to committee. And while he's up there, I'll take a moment to explain the brown jackets or the camel jackets that Senator Clifford is wearing, and some other folks, Gary in the audience, and Jim, Representative Minix, and myself and Bueller. So it's hump day. So that's why we wear camel jackets on Wednesday. So just so all of you don't think it's a little weird, there is a reason behind why we're all wearing brown jackets today. So anyway, yeah, we're not a cult. So anyway, yeah. So with that, Senator Clifford, welcome to committee. No stranger to this committee, and we're just happy to have you. So
thank you, Chair Carpenter and Ranking Price, or Ranking Rees. Sorry, Ron. Yeah, it's good to be back. I was on this committee for 3 years, so it's good to be back here with you, and it's nice to remember our colleague Les Mason, who was the head of the Camel Club. But thanks for having me today. I'm not in any hurry to get to Utilities Committee, so I'm glad to spend the time here talking about medical things. I'm a board-certified ophthalmologist, but what I'd like to tell you is that means I certified in the mid-90s, but I've recertified twice. So we ophthalmologists are held to a very, very high standard, and this year I'm contemplating recertifying for the last time. So every 10 years we actually certify, and we don't certify for life as ophthalmic professionals. We have 50 continuing education hours per year. It's a staggering amount. If you wonder why doctors go to a lot of meetings, that's part of it, just to get our education. We've heard a lot about, doing procedures and having training. I assure you that when I trained, and I trained 5 years beyond medical school, I did hundreds of laser procedures under supervision. So I didn't meet someone in a hotel or elsewhere, and I would question anyone who would train on patients in Kansas, because that would be outside the scope of optometry. So I would assume those types of trainings are on Model Is, which certainly are not moving. But I appreciate the opportunity to be here today. I am in opposition to House Bill 2223, but I'm not here to represent a profession. I'm here to represent patients, and those patients are our constituents, and your decisions are about what level of care do we want for our families and our patients and our constituents. Remember, our patients aren't here with lobbyists. They're not represented by business interest, and they unfortunately have no voice. So I'm here today to give patients voice. This is a very typical optometric clinic. I have the highest regard for optometry. These are my colleagues in Western Kansas, and we could not function, we could not take care of all the rural patients from Garden City without our optometric colleagues. It is very retail-based. They are experts in glasses and contact lenses, and as you've heard, some medical treatment. My own children, when they need glasses or contacts, go to the optometrist. I can do it, but I consider them the experts. This is my office, and this is our waiting room. We're not selling anything. We're providing care, both medical and surgical eye care, and we do a lot of it, including over 1,000 laser procedures per year. This is my world in Garden City in southwest Kansas. It's 140 miles to the nearest ophthalmologic practice. We end up seeing patients from 6 states. We satellite to Colby, Kansas, and Lamar, Colorado. So we see patients from Nebraska, Colorado, New Mexico, Oklahoma, Texas, and Kansas. In that catchment area, there are over 40 optometrists. So I'm very familiar with their training and with their ability. And believe me, every one of them has my cell phone. And if a patient needs to be seen, the answer is yes. We have 3 surgeons in our practice. We've always employed a part-time optometrist for their particular expertise. Pictured here in the middle is our former founder who died due to Parkinson's disease, Luther Fry, in September. I want to present a couple cases to you. We see a lot of patients on referral, as you would imagine, from that catchment area. About 80% of those diagnoses are correct, and 20% are incorrect. And I want to make a point about that. We do a lot of lasers. You heard about the laser procedures that are being taught at some level. 2022 data would show that laser peripheral iridectomy, or iridotomy actually, is used 0 times, is billed 0 times by optometrists in states which passed laser privileges up to 2022. SLT, which I use a lot as a glaucoma specialist, 1.1% of optometrists in those enabling, at the time, 8 states utilized that code of billing. The ag laser was single digits, except in 2 states, Oklahoma and Mississippi, which were in the low teens. I want to talk to you about a red eye patient, because red eye is a very frequent reason for referral to an eye care practice. This was a patient being taken care of for 2 weeks by our, at that time, hired female optometrist who was exceptionally bright. I would have trusted her with anyone. I happened to be in clinic that day, and she brought me over and said, I can't get this patient's red eye to go away. I was about 20 feet from the patient's room, and I saw an 80-year-old man sitting in a chair, slightly slumped. And I said, when we go in the room, you ask him, can he hear a noise in his ear on the side of the red eye? And certainly, it was her patient, so she asked him. And he said, yeah, in fact, 3 weeks ago, I fell in a hotel lobby. And ever since then, I've had this swish, swish, swish in my ear. Well, this isn't a simple red eye. This is a sight-threatening, if not life-threatening, emergency called a CC fistula. The blood in this patient's carotid system is going through a hole into what's called the circle of Willis, which is the internal circulation, venous circulation of the brain at high pressure, and it's backflowing to the eye. We emergently referred this patient to KU, to an interventional radiologist for a balloon the next day to block off this hole in his system. You've heard a lot about the YAG laser today, and indeed it's a very common procedure after cataract surgery, and we do about 3,000 cataract surgeries in our practice a year, so we see a lot of patients who develop this slight clouding, and generally this is not an emergency. We have a 6-week rule, 4 to 6 weeks. We want patients in who have this condition, but again, if someone says it's urgent, they call my cell phone and the patient's seen. This patient, and interestingly, we heard about 2 complications. They're both in my talk. Hard to believe I would have both of those complications. But on the lower right is a retinal picture. This is a normal retina, an optic nerve you see, fairly bright, and a little dark shadow there, which is the center of vision. It's very hard to see, but on the upper right, there's a 200,000th of a millimeter hole in that center of vision. This is a patient who went into optometrist for a laser procedure that you've heard is very simple and generally uncomplicated, and the laser was put right through the center of her retina. We have a very small space in eye care. It's very unforgiving, and there's no room for error. This patient came in saying that although she could see the frame of a mirror, she could not see her own reflection with her right eye. Another laser patient, so I guess we'll up that complication rate to 3, because this patient came into our clinic in January of this year, seeing one of my partners who cover for me while I'm here down in Topeka. On the left would be a clear view to the back of the eye after a laser procedure. That's what it should look like. This patient came in after treatment by someone I consider to be a very experienced Oklahoma optometrist with this white snowy cloud in his eye, and he stated that he really didn't think much was wrong, but once he had the laser, there was a lot wrong because he couldn't see. This is a YAG laser done inappropriately, destabilizing the plastic lens in the patient's eye, allowing the vitreous gel in the back to prolapse forward. This patient had vision problems and pressure problems, and one of my partners did an emergent vitrectomy in order to resolve this situation. So you wonder why there aren't a lot of reports of malpractice. I'll be honest with you, we cover for our colleagues. I'm not here to throw people under the bus. And in my clinic, if a patient asks me, I'll explain what happened. But we don't make a big deal of it because we understand that things happen. There are complications out there. I think some of you received a letter or an email from Dasa Gangadhar from KCOM, the school represented by these young ladies here today. He has seen thousands of complications in his career. This condition was so interesting to us that one of my partners is reporting it to a medical journal. Finally, our colleague, who some of you may recognize from last session, gave me permission to share his experience. He had floaters 1 week while we were here in session last year. A lot of us have floaters. I have floaters. They're very common. He was leaving on Thursday. He was seeing his local optometrist the next day. He called me after he received a diagnosis of a simple inferior break in his retina. I actually called the optometrist and said, well, what about a referral? And she said, yes, it's just an inferior break, no detachment. We're going to send him to Wichita Monday, routine care with the retina specialist. Well, unfortunately, when he arrived at the retina specialist's office, he had a superior tear in the retina and a superior retinal detachment, which was sight-threatening. Again, folks don't know what they don't know, and they don't have the level of training to recognize these conditions. As you consider 22-23, please think about patients, your family members. To me, every eye is a jewel, and I know most of us, with rare exception in this building, have two eyes, but would you submit your eye to treatment with a laser by someone who did a few procedures, who wasn't an expert in this space? We don't have a problem of access. We see patients very quickly. Again, everyone has my cell phone. Most ophthalmologists work that way, and if there's an urgency, the patient gets seen. Our staffs know that. What we're seeing is a migration of optometrists and ophthalmologists, frankly, to urban areas. Data from last year shows a 6% increase in optometrists in urban areas and a 6% decrease in rural areas. Those who are laser trained, so to speak, are migrating to those same urban areas, and it is not taking care of the issue with our rural patients. So I appreciate your time. I'll stand for questions at the appropriate time.
Very good. Thank you, Senator. Representative Blex.
Thank you, Mr. Chair. Yeah, great to see you again, have you back here in this room. Enjoyed with you, serving on this committee with you. We've heard another presenter state that out of 146,000 plus operations or whatever, issues, that there was only 2, and you've listed some of yours, potentially complications that you've seen after an optometrist had seen them. Have you or any of your partners had any complications that you can recall?
You bet we have. We tackle the hardest cases imaginable, and we live with that. I call every patient the night after surgery to make sure they're comfortable, and I'll see them if they're not. But we are there to take care of people. You know, I could trivialize these procedures. I know what Dr. Bryce said before. I could probably teach my son in a video game to do something like a YAG laser capsulotomy, but it's about knowing when to do it. And again, 80% of the referrals I get are correct, but the other 20%, I can give you a long list. You know, brain tumors, MS, retinal hemorrhages, diabetic eye disease, optic nerve disease. Again, I've had an advantage. I went to medical school. I did neurology for 6 weeks. I was in a surgical ICU. You can't replace that. It's one thing to do procedures. It's another thing to have the knowledge and the wisdom to do it at the right time.
Thank you for that, and thank you for being here.
Committee, further questions? Representative Bryce.
Thank you, Mr. Chair. I couldn't avoid asking you a question, former colleague.
Thanks.
You were mentioning, I'm trying to understand, of course, in ophthalmology, residency ophthalmology training, you're trained in these procedures. Do you have any idea about how many optometry schools train students in the procedure? I might have missed that in these procedures.
Previously, there have been 2 schools in states which would even allow this. So unless folks are breaking the law, they couldn't possibly be doing this level of training in 24 schools. Only 2 schools are in states until this year that even allow laser treatment.
2 out of 23 schools?
Correct, 24 I heard.
24. Where do, if optometrists are receiving all this training, where are they receiving it if not in the schools?
Well, I think you've heard it from a prior conferee, but again, I would question doing live patient treatment in a state which doesn't permit this by this level of practitioner. So again, I'm not the State Board of Healing Arts. You'll hear from them separately, but that is a concern. You can practice all you want on model eyes. I mean, I go down to the slaughterhouse and get a bag of pig eyes if I'm trying something new surgically, but there's a patient moving on the other end when you're doing lasers, and it is not easily, it's not trivial, and the consequences are dear.
Very good. Thank you, Dr. Clifford.
Thank you.
Representative Ruiz.
Welcome, Senator Clifford.
Thank you.
You and I have had, in the past, we've had discussions about this and about your practice that I very much admire. The picture on the optometrist's office on your slide is, I had to chuckle a little bit. I know that when I go to my optometrist or my previous optometrist, she was an optometrist in a practice with several ophthalmologists, and she was the one optometrist. And this picture looks very similar to that one, but they all shared it. So, you know, there's a separate waiting room for the patients to be seen, but this is the optical department picture only, that anytime the optometrist or the ophthalmologist saw a patient, they could go over there and just browse, you know, to look for their glasses. So it's not the totality of their practice.
I was trying to make them look good.
It's a beautiful office, that's for sure. And I've worked for optometrists before, and it's you know, there's always a separate waiting room for the patients. And the optical part of it is, it's just for you to go and look at glasses, you know. So I just wanted to point that out, that this is not the totality of the optometry practice with this.
You're correct, and many of my colleagues do optical. Yeah. You're correct. Yeah. We in the rural areas choose to stay in our lane and do surgical and medical eye care because that's the priority. That's how we can take care of all of the patients. We would ask our colleagues in optometry to similarly respect the lane because we need them in rural areas to take care of primary care, primary eye care. They're very much needed.
Senator Clifford, I have another question. You know, with the use of the slit lamp, you know, and I have seen the machine that is used for the laser, and it looks just like a slit lamp. You know, can you explain to us the differences between the two?
Well, you know, my practice owns 5 lasers, and there are many, many more. In eye care, we kind of cut up the eye in different ways. The slit lamp is used as the base instrument, and often the lasers are attached to the slit lamp. Again, when you're observing a patient, you're generally not putting a lens on their eye with your hand extended and the patient moving around, trying to put that 200 micron laser beam in the exact correct position. So making it, I agree, the slit lamp's the base tool. It's another level to do the surgery.
Representative Turner.
Thank you, Mr. Chair. Say, quick question. I was trying to understand your 80% referrals correct, 20% incorrect. When they're referred to you, are they telling you this is the diagnosis and I'm sending them to you specifically for this, or are they giving you a general referral for you to make that diagnosis?
Representative, that's a good point, and we heard from prior conferee who has a visiting ophthalmologist. Generally, these patients are pre-screened. I'm going to a hospital where I have very little equipment, and I'm counting on the optometrist to have done all of the testing. So I look at their diagnosis. It's a hazard not to look at the optometrist's opinion because they probably know the patient well, having seen them over time. I'm here first day seeing them. I review the testing, and then I make my own diagnosis. And I just did 9 lasers on Friday in Colby. It's not 80%, but 2 of the 11 referred to me I didn't do because they were incorrect diagnoses.
Thank you, Mr. Chair.
Representative McDonald.
Thank you, Mr. Chair. I appreciate you being here, and I've enjoyed working with you as a colleague. I'd be remiss if I didn't say something right now, though. I heard you say 2 things that kind of perked me up and surprised me. I heard you say the female optometrist, and I'm not sure what her sex had to do with it. And then another thing you said is we cover for each other. And, you know, if that is the case, you're kind of talking us out of maybe listening to the perspective. If we're minimizing the problems that these optometrists are doing, I don't know. It's just those 2 things really bothered me. So I respect you enough to be able to say that to you, and I just would like for you to reflect on those. Thank you.
I would say that I said she was a female because she was very bright. But we also, it's not a criminal cover-up. We're colleagues. We're fixing the problems. That's what we are doing when we see these referrals.
Very good. Thank you. Representative Weichel.
Thank you, Mr. Chairman, and thank you, Senator and Doctor. Can you provide a little more clarity to me on the 3 examples that you gave, the red eye, the laser, and the retina, the detachment? Were those complications like particularly related to the expanded scope of practice that the optometrists are asking for in this legislation?
So I would say no to the red eye in particular, because that's a fundamental diagnosis in eye care. That's just somebody who didn't have medical school, who didn't have the differential diagnosis that I had in my head, because I did neurosurgery, I did neurology, I did so many weeks and months and years of systemic medical care. A laser procedure, it's a skill. And if you don't know where you are in the eye, and you can get lost in the eye if you're using a lens. Often we have a lens that actually is looking down, not up, or it's looking backwards. Our picture, often, I showed you pictures right side up. When we look at the eye and the retina, we're looking at the eye upside down and backwards, and you have to translate that in your head. And if you don't know where you are, you're going to put the laser in the wrong place. Detachments, again, it's experience. It can be missed by many doctors, but you have to know where your limits are, and if you don't know what you're dealing with, you have to refer it right away.
I had to follow up. Thank you, Mr. Chair. Follow-up question. So it sounds like in those instances, at least the first and the third, the referrals were made and the correct diagnosis was eventually done. But I guess my follow-up question is really, given that you see patients from Oklahoma and other states, have you seen people come into your practice because this scope of practice that is being discussed in this bill was done incorrectly by an optometrist in Oklahoma?
Yeah, that's a good question. I think, rural areas, people meet at the coffee shop and they meet at the elevator and, at the farm sale and the barn. People talk. You all make a sacrifice to be down here in Topeka, as do I, financially. It costs me to testify like this. I have optometrists referring around me because of my testimony here in Topeka. And that's the price I'm willing to pay, again, because it's for patients. But I don't go out downtown and talk about these referrals. The patients, or these problems, the patients do the talking.
You may.
So I just want to make sure I'm clear. I'm taking away from that answer that you have not had a case where the scope of practice discussed in this bill was done incorrectly in Oklahoma and then referred to you.
Well, the second laser case was done rather inappropriately, and we ended up doing emergency surgery on that patient. We had done the laser on his other eye previously, so he knew what he was getting, but he expected to see better, and when he didn't, he came right up. He came on his own.
Was that done by an optometrist?
Yes.
Okay, thank you.
Very good. Representative Gardner.
Thank you, Mr. Chair, and thank you, Dr. Clifford. We're elected to be policymakers here, and that's our primary role in this. But in your professional opinion, is there enough agreement within the body of get the right word out here, of ocular professionals for us to be making public policy at this time as we're being asked to do?
Well, as an opponent of the bill, I would say emphatically no. I think with time there may be an evolution of training, but I don't think it's there. And I don't know how you make up for the lack of medical school and the knowledge of what's behind that 1-inch little organ there. I mean, that part you can never recreate.
Thank you very much, and thank you, Mr. Chair.
Representative Steens.
Thank you, Mr. Chair. And actually, part of my question was already answered. And thank you, Senator and Dr. Clifford, for testifying today. I know this is really a delicate, obviously, practice here, and I've worked with some ophthalmologists when I worked with a lot of stroke victims. I'm just curious, is there, not to put you on the spot, but are there, I know you spoke about the young lady, I think she was the optometrist. Is there, and there's optometrists in your practice, are there any of those that if they prove the competency of these, just these particular procedures that are being mentioned in this bill, that you would be comfortable with some of your optometrists performing? Or is it just something that I know you said you were, obviously there's a lot of complexity to this, but.
So when I trained, I was directly supervised for 4 years of surgical eye care. And I certainly have trained residents too. We host KU residents in our practice, and we sit right with them for surgery, lasers, even in the clinic. So there's a role there. I will tell you in our meetings with optometry, we have pursued a ruling from the State Board of Healing Arts because we physicians have delegatory authority. I mean, I delegate to technicians pressure checks, refractions, many things. I have that authority, and at higher levels of training, I can delegate more. I delegate a lot to our employed optometrists, not surgery. On the optometry side, and they maybe could answer, their State Board of Optometry has been asked to approach the Attorney General. We presume they're doing this now to see if some of these things could be done under delegatory authority already. I don't know that their profession wants a two-tiered profession, those who can and those who can't. But again, under the proper level of supervision, direct supervision, I could, these are bright, skilled people, but I would never want it to be done without supervision.
Thank you.
Representative Berquist.
Thank you, Mr. Chair. Thank you, Doctor and Senator, for your being a cohort in this body in the past and for serving in the Senate. So one of the questions that has come to mind, has come in conversation in the past over the same discussion, is what something you mentioned a while ago about things being done in hotels as far as training. What training is that gets done in hotels?
Well, I mean, I go to Chicago and New Orleans, California for meetings, and we, shoot lasers against a piece of paper or against a mock eye. We sure don't treat patients. I'm not licensed in those states. So, I mean, we have continuing education requirements, 50 hours for me. When I've learned surgical procedures, and I've done FDA studies on devices, we go out of the country. I've been to Panama and Mexico, again, under supervision of experienced ophthalmologists in those countries to learn new procedures. I was in Tijuana 8 years ago to learn a glaucoma procedure for an FDA trial. While I was there, there was a doctor in another room named Arturo Chayet. He's world famous, doing his 600th light adjustable lens. We heard about the light adjustable lens. It was unheard of in the U.S. at the time. And here he is doing his 800. So, and actually most of the people from San Diego crossing the border to get it done by Dr. Chayet. So when we train, we really, we're not going to do a one-off and then go treat a patient. And I always inform patients. I say, you're my first patient doing this. Now, I have 30 years of ophthalmologic training, and I have the skill set, but this is a new procedure for me. But we do a lot of reps in many different ways. We go to others, ophthalmologist clinics, and make sure that we're competent before we proceed.
Thank you. Could I have just a follow-up there? So we're back to the question of say, people that have gone to and done their training as an not as an ophthalmologist, but a
optometrist?
Optometrist, yes. I get a lot of opti words kind of mixed up there. I'm glad I'm not one. But the ones that train in Oklahoma, they got their training at the college. Is that correct?
Yes. That's
as far as you know, yeah. So that's the wording, and going back to the hotel room kind of thing makes it sound like it's some kind of a weekend adventure rather than a training like you've experienced for many years and continue to learn and train for your profession. So I just wondered why that comes up in conversation as far as the description of some training in a hotel room.
Again, you can't do it on live patients unless as physicians you do it on each other. Probably could stick a needle in your friend, but you're going to do suturing on a flank steak, frankly. And if you're doing laser, you're going to do it against a paper target or a model eye. You're certainly not going to do it in a live patient without breaking the law.
Thank you for your professionalism. Thanks for your question.
Thank you.
Representative Bueller.
Thank you, Mr. Chair. Thank you, Dr. Clifford, for being here. So I want to make sure I understood the dialogue between you and Representative Gardner on it, because I think I heard you say, or the question interpreted, who's responsible for establishing legislative policy, or in this case, law, when it comes to scope of practice? It is this body, is that correct?
That's correct.
That's correct.
For optometry, not for medicine.
This is our job here with this bill. So, and I get back to your profession. Are there things that, and you've been an ophthalmologist for how many years?
35.
So in those 35 years, are there things that you're doing today that you had no knowledge of or were doing 35 years ago?
Nothing I do today is what I did 35 years ago.
So it's all changed.
I learned the basic skills to do it, and I built on those, but it's all changed.
So it's and that's kind of where I'm going. So there's been an evolution, not only in your learning and what you apply in your profession, but the same thing is true in optometry. Is that correct?
That's correct.
Okay. So when someone says, hey, we're learning the same, and maybe it's, because what I understand from my colleague over here, what I hear is continuing education. denigrated to the point of being in a hotel room and denigrate, and continuing education happens. But I'm referring to training on these procedures. Some of these basic procedures, it's going to be this. It's going to be taught to you the same way it's going to be taught to somebody who's an optometrist. You're not going to dumb down the training for someone who's in ophthalmology school versus someone who's in optometry school. Is that correct?
That's correct.
Okay. And I guess what I kind of want to make sure I hear is we're not, there's not an establishment of a lower standard for these procedures for someone who's an optometrist or someone who's an ophthalmologist. That's right?
Certainly, we've heard no numbers about the number of trainings, the number of lasers. I would say the number is vanishingly low compared to the hundreds you do in ophthalmology training. Another of our conferees may allude to the training at KU.
I'm just trying to establish that the standard of training is the same, and the learning outcome would be expected to be the same.
I would think so, but, human anatomy hasn't changed. Brain's circulation in the brain, the fundamentals of taking care of a system that's attached to the brain hasn't changed, and that learning is steep.
Right. I agree. So thank you, Mr. Chair.
Representative Droege.
Thank you, Mr. Chairman. Thank you, Dr. Clifford.
I'm sorry, Mr. Chairman, we're on final action in the Senate. Is there a way I could yield to another conferee?
There is, and I was going to ask if we could wrap this up in the interest of time. And I want to give everyone the latitude that they need, but I get that. So, Dr. Droege, Representative Droege, is that okay with you?
It's okay. Representative Clifford, or Senator Clifford knows he will understand what I say, so it'll be no problem.
Okay, very good. Thank you.
Thank you, Tom.
Thank you, Senator.
Thank you, committee. Appreciate it.
Okay, moving right along, committee, because we are.
I do want to say what I had to say, though.
Yeah, why don't you go ahead can you state your question?
It's sort of a question, sort of an agreement. Optometrists we have do a wonderful job. But I think what Dr. Clifford was alluding to, and a lot of what this discussion is the level of education and expertise behind things. We have to remember the patient, and if you have the training and the ability to look at the complete evaluation and do your differential diagnosis, as he mentioned about walking up to that patient, and before he even went in the door, he had other diagnosis going in his head. And I think that the deeper education allows that to be a more important thing or a more complete thing in the entire care of the eye, since it's such a fragile situation. So I just was trying to, I guess, extend that, because we kind of got away from that basic thought that having that complete education to be able to evaluate from a distance and have differential diagnosis come into your mind even before you've seen the patient, because you have much more education behind it. Thank you.
Very good. Thank you for that. Next, we have Dr. Murray. Welcome to committee.
Mr. Chairman and members of the committee, thank you for your time. My name is Mary Champion. I'm a physician ophthalmologist, and I appear today as the president of the Kansas Society of Eye Physicians and Surgeons on behalf of the ophthalmologists who practice in Kansas City. I practice ophthalmology in the Kansas City Metro. The Kansas State Legislature and those who regulate licensed professionals assure that the individuals providing healthcare services are qualified. This is critical when considering.
Doctor, excuse me, can you move the mic down just a little bit so we can hear you better?
Sorry
about that.
Shorter than all the other.
There
Is
you
that
go.
better?
That's better. Thank you.
This is critical when considering the procedures in this bill. All lasers, surgeries, and injections involve risk, whether you use a scalpel or a powerful laser that burns or cuts parts of the eyelid or the eyeball. The eyelid measures millimeters thick, and the target for the YAG laser you've heard about is 5% the thickness of a human hair. The margin for error is extremely small. This bill would also permit the removal of lesions without known malignancy, but no lesion has known malignancy until it's evaluated under a microscope. Improper technique or removal of these lesions can lead to spread of cancer throughout the body, scarring, disfigurement, or even blindness. There's not an access problem for Kansans to reach qualified ophthalmologists for any of these procedures in the state. 97% of Kansans reside within an hour's drive of an ophthalmologist, and 92% are as close or closer to an ophthalmologist as they are a Walmart. There's no reason to change the standard of care in Kansas. There's also no evidence that recruiting optometrists to Kansas is problematic with the current scope of practice. Kansas has the third highest number of optometrists per capita, and that's higher than all of the states where laser or lid surgery is already allowed. You'll also hear from Dr. Unruh today that surgery requires medical school and residency training, not just lectures or practice on inanimate objects. When patients see us, they often ask, how many of these have you done? And how long have you been doing this? Those are all ways of asking, do you know what you're doing? And I think that we really have to think about that. Kansans deserve to have the most qualified surgeons performing eye care, lasers, and procedures on them. So on behalf of the patients that we serve, we ask that you retain the current provisions in the optometry scope of practice and oppose House Bill 2223.
Very good, Doctor. Thank you for that. Committee questions? See, Representative Bryce.
Hi, hi, Dr. Champion. Thank you for your presentation. When we started this conversation, it seemed to be kind of the question of whether optometrists could be taught to do the technician, the procedure, and I think we've heard these procedures, and I think we heard that from Dr. Clifford that a lot of these procedures, just a person could be taught the technique of a procedure, but then as Dr. Droege or Representative Droege and Dr. Clifford and some others were saying, the other question I think we're really talking about here is the foundation of knowledge, of knowing, as Dr. Clifford said, what's behind the eye, what's behind the 1 inch with the red eye patient and so forth, to have a more holistic approach. And that only comes with medical school at this time. And I just wondered if you see that as true, that really the question is whether there's an underlying knowledge and a base and of the medical profession. It's not just whether or not it's technically possible to do a YAG laser appropriately. Thank you.
I think the answer is yes. I tell my residents every single day, they're in the clinic, they're in the operating room, they're really excited. And I tell them all the time, the hardest thing that we do is not the cutting. It's not pointing the laser. It's not pushing the plunger. Dr. Clifford said, I could teach my son to do this on a video game. That's not the hardest thing that we do. The 10 years that I trained, it wasn't the number of procedures. It was, how do I think about the patient, their vision, their eye, their aftercare, how they're going to take care of themselves. When I should be doing these procedures, if it's the correct procedure, am I the best person to do this procedure? And that's more than a course. It's more than a log of procedures. I think it was your question, Representative Bueller, is there a difference in the training, the standard of training between optometry and ophthalmologists to achieve these lasers? I think there is, and there is a mechanism for anybody who went to optometry school to learn these procedures. It's acceptance into medical school, 4 years of medical school training, 4 years of residency, and then optional fellowship, trained by people who were trained by people who went through that exact same training, and surgeons who hold ourselves to the same standard.
Any further questions? Seeing none, thank you very much for being here. Next, we have Dr. Zach, virtual. Are you there?
Yes, I'm here. Hi, can you hear me?
We can hear you fine.
Hi, Mr. Chairman and members of the committee. Thank you for having me. So my name is Zach Unruh. I graduated optometry school from the University of Houston College of Optometry in 2010. I practiced for 7 years in rural Kansas. And then I went back to medical school, University of Kansas for 4 years. In 2021, I graduated. and I came down to Texas. I'm in my 4th year of residency here, and next year I plan to do a 2-year fellowship in vitreoretinal surgery, and I'm moving up to Columbus, Ohio. The goal of my testimony really today is just to provide a brief review of my experience, kind of in both training grounds. So optometry school, my experience, the bulk of direct patient care came kind of during the final year of training. We had community clinics that we rotated through. It was a mix of routine eye care. We treated some chronic conditions and then learning to recognize emergencies and referring appropriately. My logs, I estimate I graduated with about 1,500 patient encounters. Most of that was routine care. And then once I started practicing, I really started to feel comfortable with the pace of a full clinic and kind of with my decision making, kind of around that 2-year mark into private practice. So contrasted to residency, it starts with a year of general medicine and then followed by 3 years of ophthalmology training. I do about 60 hours a week, seeing patients in the clinic, in the OR, studying for our weekly conference, preparing grand rounds, journal club, practicing in the skills lab, and then I take call 2-3 nights a week as well. Total of 4 months of this training was seeing urgent referrals, hospital consults. These were vision-threatening and life-threatening pathology. To date, I've logged over 5,500 primary patient encounters and about 900 procedures in my residency. All these procedures require supervision from the pre-op counseling to the post-operative care and everything in between. So through all of this, I feel like the largest difference I've noticed is really my mindset, my approach to healthcare as a proceduralist versus a primary care provider. It's the ability to not just handle unexpected problems during a procedure, but also to anticipate and avoid those complications if possible. It's been said already that the most difficult part of these things is not the mechanics of doing a procedure, but it's in the preoperative planning, it's in the counseling, it's in the decision making, who to do the procedure on, who not to do the procedure on, when it's appropriate. And there's really a lot of subtlety there. There's a lot of nuance that takes years of training and practice to refine under supervision. So, I really value the optometric community and the time I spent practicing. Eye care certainly would not be possible without that contribution. Fortunately, as an optometrist, I mean, we all make mistakes. The mistakes that I made as an optometrist were reversible, and that there's really no long-term consequence there. But for me, the most difficult part of residency has been the lesson that when you start manipulating human tissue, you can't go back from that. The patient really has to just kind of live with the consequences of your actions. I really didn't know what to expect going into residency. I expected to be different, but just the starkness of the difference is just overwhelming in terms of kind of the 180 that I've had to do in my mind to really look at things differently. I appreciate your time. Thank you for your consideration.
Very good. Thank you, Doctor. Would you stand for a few questions?
Sure.
Representative Bueller.
Thank you, Mr. Chair. Thank you, Doctor. When you were in optometry school or as an optometrist, were you trained to do the YAG capsulotomy, the SLT, and the PI peripheral iridotomy?
We did a skills lab where we practiced on rabbit eyes, but that was like one afternoon.
But you were trained to do those, and that was in the state of Texas?
That was in the state of Texas. I mean, trained to do them is not, I wouldn't say that. Like, I clicked the laser a couple times, but this again was in like 2006 to 2010.
Okay, I'm just trying to, the testimony that we've heard today, part of that, part of the dialogue has been that the training is the same, whether it's in an optometric school or ophthalmologic school, however you pronounce that, on those 3 techniques. So I'm trying to ascertain whether, in your opinion, as an optometrist, they're going to get a different level of training on these 3 techniques as you, as an ophthalmologist, would have received. Is that true or not?
I can speak to my training back in 2010, and it's very different.
Okay, so in your opinion, has the level of training and the type of training since 2010 changed? It's 15 years later.
I imagine that the type of training has changed some, but I cannot imagine a situation where it has changed to the extent that what I've been trained in the last 3 years.
Okay, so then I'm hurrying questions because I have my own committee in about 10 minutes I need to leave for. So tell me about complications that you had either as an optometrist or now as an ophthalmologist. Do you not experience complications as an ophthalmologist? Are they the same? You've
No,
kind of,
there's
you're one
definitely,
of the few that's been in both worlds for us.
right. Right. So complications, just in general, broad terms, as an optometrist using therapeutic and diagnostic eye drops, most of that is reversible. You can reverse what you did, or something will wear off. Versus like in surgery, if I do something where there's a complication, you have to completely change your approach, do something different, not do your original plan of what you did, and sometimes have to do additional procedures and surgeries.
Okay. I think I've run out of questions, Mr. Chair. Thank you very much.
Very good, committee. Further questions? Thank you so much for being here, Doctor.
Thank you.
And next, we have Rochelle Colombo. Rochelle, welcome to committee.
Thank you. Good afternoon, Mr. Chair, members of the committee. I am Rochelle Colombo. I'm the Executive Director for the Kansas Medical Society, and we appreciate the opportunity. I think this has been an excellent hearing with a lot of information, but we are here in opposition to House Bill 2223. You've heard a lot about these procedures and about what's trying to be decided. So I want to give you just a very broad overview of why we oppose this bill. First and foremost, we do not support the practice of medicine by non-physicians. And you could look at that and you say maybe that's competitive, or you think of it as a turf battle, but the bottom line is that the standards and the regulation and the training are not the same for different provider types. And I think there's been really good discussion today around education and foundational education. And so what we are talking about and the procedures that would be allowed in House Bill 2223 are surgery. They're not just procedures. They're not just something that is one and done. They can have complications. They can have other effects. Individuals outside of medicine are not given the same training. They do not have a differential diagnosis. They are not able to identify some of those other complications. And so while they may be proficient in a procedure, they are not trained for the full focus of medicine. And that is the crux of our opposition and why we believe that this would not be appropriate. Secondly, they're not regulated in the same way. Not only are they not trained in the same way, not going through 4 years of medical school onto a 3 to 7 year residency and a 1 to 3 year fellowship, they're simply not trained in the same fashion and as inclusively or as expansively as you would be in the medical school. They're also not regulated the same way. They are not required as a condition of licensure to carry malpractice coverage. And we don't believe that this serves patients well. They would not have the same right of recovery that they would have if they were to see an ophthalmologist and have a bad outcome. Optometrists used to participate in the Healthcare Stabilization Fund, which is a condition of licensure for medical doctors and doctors of osteopathy, but they opted out of that about 10 years ago. And the reason was they said, we're not doing invasive procedures. We're really not seeing claims. There's really no need for us to participate in this. But if they are looking to expand their scope and to have extensive procedures, these are surgical and they are serious, they ought to be a part of the Healthcare Stabilization Fund and should be regulated in the same way. So, we really feel that those things protect patients. It's a matter of consistency, and that is the full goal on this. And so we would ask you respectfully to oppose House Bill 2223, and I'd be happy to answer questions.
Very good. Thank you very much for being here. There may be a few questions. Representative Blex.
Thank you for being here. The bill does not specify a contribution to the Healthcare Stabilization Fund, does it?
No, they are not defined healthcare providers under current law, so they would have to be added into the Healthcare Stabilization Fund if that were the will of the committee, and that's what we would recommend.
Thank you. And one more follow-up. I'm assuming if this bill is passed, then either that board or their board would require that or mandate, or you guys mandate they be in the healthcare stabilization.
It would require a change in the law. You can't, so a healthcare provider can't just opt into the Healthcare Stabilization Fund. It has to be written through statute, and the fund law would have to be changed to include them. So we would suggest that if it is the will of this body to pass this legislation, they ought to be included in the Healthcare Stabilization Fund. And if I might, one more point. While this issue has been discussed for many years, and I would agree with my colleague who said, you know, they brought this in 2020, it's a was a tough time to try to get healthcare legislation through. There's been discussion, but there is no compromise on this bill. There has not been agreement on these procedures for specific reasons. And while we've been talking a lot about the details of eye surgery, which I think all of us are pretty unfamiliar with, it really goes beyond that. This, again, is the practice of medicine. It is more than just procedures. This is extremely extensive and would be allowing non-physicians to do surgery. And I think it is a very broad expansion with very, very serious implications. There ought to be more discussion, and there is no compromise at this time.
Thank you. Thank you, Mr. Chair.
Committee, further questions?
Thank you.
Okay, very good. Thank you very much for being here. Committee, this is why we love these scope bills. But I will tell you, I appreciate all of you. Oh, I'm sorry. I got ahead of myself. Yes. Susan Giles with the Board of Healing Eyes. Sorry about that.
You're fine. Good afternoon. I definitely so happy to be the last one here. Chair Carpenter and honorable committee members, thank you so much for allowing me to speak before you today. My name is Susan Guile. I'm the executive director of the Kansas State Board of Healing Arts. I will try to be quick. I don't have much to add that the other conferees haven't already talked about. I do just want to highlight a couple of things. I would agree with really, although my testimony is neutral, I do agree with most of what the proponents have talked about. I am very concerned about this bill. This is, the use of lasers is the performance of surgery, and that is the practice of medicine, and does require either an MD or a DO to perform. If you look at, and it's in my written testimony, KAR 100-27-1 does require that you have an MD or a DO to use lasers. It does give delegatory authority to do that if you are physically present. So an optometrist can perform these procedures right now under the delegatory authority of an ophthalmologist if that ophthalmologist is physically present. That can happen today under that reg. The other thing that I want to highlight from my testimony that we have not talked about today is that section 1, paragraph 1 removes topical when discussing the optometrist prescriptive authority, and that just makes me wonder what the level of prescriptive authority then is for the optometrist. Can they prescribe opioids? And are they required then to do training for that? I think it leaves that really open and begs questions for me. Section 1, paragraph 2 discusses the use of medical devices. There is no definition of what constitutes a medical device. And I think that too would need some further clarification. And I think everything else as it relates to the use of lasers has been discussed as much as it needs to be. So I would stand for questions and yeah.
Very good. Thank you for that. Committee questions. Representative Bryce.
Thank you, Mr. Chair. I know it's tough to be last. Everybody's wanting to get out of here.
3:29.
But I have to say, something you said was the most important thing to me, one of the most important things in this whole hearing, and I hope we're not so tired that we missed it, but you said, as of today, optometrists can, in the state of Kansas, do these procedures.
Under the delegatory authority.
So they just have to have an ophthalmologist who trusts them, and they can do these procedures.
And is physically present.
And physically present? Okay.
Correct.
I just wanted to clear that up. Thank you.
Committee, further questions. Representative Howell.
Thank you, Chair. I don't know if it's appropriate to ask for a researcher or of our conferee, but I would like to know information of the syllabus for the 4 years of optometry school compared to the 4 years of ophthalmology residency.
I think they can
That's
gather
not,
that.
that's not me.
Specifically for the residency, not the medical school, because the medical school doesn't specifically deal with the eye.
Jen, are you looking?
Yeah, that's not me.
Okay.
Oh, okay. Hang on. Any other questions while we're waiting for that? Yeah, I think we'll have to get that in the interest of time here. We do have another committee coming in here at 3:30, so any other questions of Susan? Seeing none, thank you very much for being here. Now I will wrap up committee.
Thank you so much.
Sorry. Thank you for the brisk dialogue. It is great. And I appreciate, and I hope a lot of you got your questions answered. And with that, we're adjourned. We will work this bill tomorrow.